We are on the record at approximately 5:31 p.m. This is the beginning of disc 1 of the video deposition of Dr. Carl Coghill. Would counsel present please identify themselves and who they represent for the record?
Heather Miller here on behalf of Dr. Onasanya.
James Potts on behalf of Keandria Williams.
Would the court reporter please swear in the witness?
Raise your right hand. Do you solemnly swear or affirm that testimony about to give in these proceedings will be the truth, whole truth, and nothing but the truth so help you God?
I agree.
Hello, Dr. Coghill. How are you?
Doing well, thank you.
You understand that your deposition is a public document? True.
No, I don't know anything about it. But
Okay.
If it is, it is.
All right. Have you ever given depositions before?
I have.
All right. About how many times?
Oh, gosh, over the last 30 years, maybe 10 or 12.
Okay. And were those on behalf of a doctor or a hospital or
Well, there have been a couple as a treating physician, I guess, just as the treating physician, not having been in the suit or an expert. And then there are, there's one for a plaintiff's lawyer, and I guess the rest would be his defense cases.
Okay. So you think you've testified on behalf of a patient one time?
I think I've only done a deposition, it might be twice. I did 2 cases for him. I don't know if the other one got to be to a deposition or not.
Okay. And the other 10 or 11 cases were on behalf of a doctor, is that right?
Objective one.
Or hospital. Yeah, I think more of them were for a hospital than a doctor.
Okay, so the other 10, 11 were on behalf of a doctor or a hospital, true?
Yes.
And do you have a list of those cases?
Well, I'm sorry, the 2 I did as a treating physician, I don't think were really for anybody.
Yes,
They
sir.
were just, I treated the child here once it was referred.
All right.
So
And you've never been named in a lawsuit yourself?
I was named one time years ago, but I was dropped before the case came to trial.
Okay. All right. So, yes, your deposition is a public document, all right? It's available to your colleagues here at UAB and Children's of Alabama and any residents or fellows you may teach, nurses, other lawyers, things like that. Were you aware of that before now?
No, but that's fine.
Okay. And it's also available to your boards. You're a board-certified pediatrician, true?
Yes.
And your deposition's, of course, available to your pediatric board?
Well, I get
All
public,
right.
everybody.
Gotcha. And you're also boarded in a subspecialty as a neonatologist, true?
True.
Your deposition is available to them as well.
Okay.
Are you aware of any of your depositions ever being sent to your boards? Were you ever contacted?
No.
Okay.
I've never been contacted that any of my depositions were ever sent anywhere.
Okay.
So I don't know what happens to them.
All right.
All right.
You've never seen one of your depositions on YouTube, right?
I've never looked.
Okay.
So there could be some there. I don't know.
You haven't seen them, true?
No.
All right.
None of my friends have called to tell me they saw me.
The point is, your testimony will stand for you outside this
Yes.
one limited case, true?
Yes.
Now, when were you first contacted about this case?
I don't know. I guess sometime last spring or early. I don't know.
Okay, sometime in 2016?
I think so, but I mean, I would have to look back at the letter they sent.
All right.
But I don't have that with me. Well, I do have it, but it's on this little computer chip.
Okay. Do you have a copy of the deposition notice?
No.
All right, have you seen this before?
No.
All right, I'm going to show you what's been marked as Exhibit 1, which is your notice of deposition. And attached to that is Exhibit A, which is a notice to produce. Have you ever seen that before today?
No.
All right. It says here that you're required to bring with you all notes, diaries, letters, reports, statements, or other tangible things documenting, recording, reflecting, or otherwise referring to any conduct of the defendants or plaintiffs' alleged injuries in connection with the facts forming the basis of this lawsuit.
Okay, well, I don't have the emails, but
All
we
right.
can always get the emails.
Okay.
And that's all the records I have
All right. On this chip.
on that chip.
All right. Mark this as number 4.
And James, are you gonna want the court reporter to keep that chip?
Well, I can leave if he just wants to electronically send me what's on the chip. He
Yeah,
can
I'd like for
keep
him to
it.
keep his documents.
But I still want
Yeah.
either a photograph or I want to show what that this is what you brought,
Okay.
right?
That's what I brought.
And
And I also had
yes, sir.
a disc with the x-rays, but I don't know where that is anymore.
Okay.
So,
You don't know where it is. You don't want.
no, it's in my house. I'm certain of that,
Well, those-
but I don't know where it is, and I couldn't find it when I was looking for it. So
Now, those X-rays, are those all plain films?
they were all plain films that I recall. I'm trying to remember. You know, I looked at the plain films. If there was anything else, I don't generally look through CT or MRI myself anyway. I would go off reports from those. So
Okay.
I looked at the plain films.
And those were
recall.
the films that were made at South Fulton Medical Center between the 8th and 13th? Is that
Yes.
right? All right.
The chest x-rays.
And those are on a disc somewhere. You don't have that with you here today?
No, I don't have it with me. I don't know that I can ever find it again.
That's all right.
But I had it.
But as far as you recall, you reviewed all the films that are
All the
referred to in
films.
the
Yes.
medical record, right?
Yes.
And I know we do that in conversation, but if we talk over one another, it'd be difficult for her to take that down. So
Okay.
I may stop you sometimes. It's nothing personal, just to try to keep a clean record.
All right.
So you mentioned the X-rays on another disc. What is on this plaintiff's exhibit 4? This chip.
There's the initial letter
Okay.
from the lawyer asking me to, I don't know if it's asking me to review. I think that was done by email, and then they sent a letter when they sent the record.
And what lawyer was that?
I don't remember
think
if
it
it
was
Dan or
actually my
Heather, actually
nurse.
your nurse clinician, whatever they call that, assistant. or
Okay.
Assistant. And then these are the medical records of mom and the child.
Yes, sir. At South Fulton
The-
Medical Center.
Yes, and at Children's of Atlanta.
Yes, sir.
And then it's the depositions of mom and dad. One of the nurses, I think her Wright, maybe, was that her name? Wright? One of the nurses. And
Okay.
then it's the depositions of Dr. Mursakis, or however he says that.
Yes, sir.
2 of his. And then the depositions of Sarah Posley and Z Blassingame,
All right.
Zadorek, or whatever it was.
Any others?
I don't think so.
All right. Did you review the depositions of Dr. Lorenz?
No,
What about Dr. Lee?
no.
Were you aware that opposing counsel had previously retained them as experts in this case?
I assumed that from comments that were made, that they were experts, but I don't even know what their fields are.
Okay. Well, neonatology.
I assume Lee is neonatologist,
Yes, sir.
but I don't know Lorenz.
You don't know?
I don't
more
know
of
Lee,
him?
but I just from
Yeah,
comments
he's a
that were made.
neonatologist as well.
Okay. Oh, they're both neonatologists.
Correct.
Okay.
And you've not reviewed either one of their depositions?
No.
All right. Any other depositions that you've reviewed?
I didn't know there were any others, but I'm trying to think if there's one on here that
I don't think you mentioned Dr. Onasanya's deposition.
Oh, on son, yes, I did his deposition.
He did, I think.
He did? Okay.
Yeah, that's all right. He said 2 of his depositions.
He said
No,
Marascus.
Mursakis, 2 of his. only saw
Marascus, yeah. I
On
thought you said.
Onasanya, I did one. He only had one that I know of. If he had
Gotcha,
two,
gotcha,
then I
gotcha.
missed one of those.
All right. Well, thank you. All right. The two of Dr. Marascus's deposition.
Yes.
Do you know Dr. Marascus?
I don't.
Have you ever heard of him?
I've heard the name
Yes,
before,
sir.
but I don't really know why. Or
Okay. You've heard of Loyola? I mean, the
yes,
okay. The program
yeah.
there in Chicago?
I love Chicago. Go up
Okay.
there all the time, but I deal more with Lurie Children's. But
More with what?
with Lurie Children's up there
Okay.
at Northwestern.
Yes, sir.
Yeah.
All right.
All right.
Anything else on this desk?
No, just that letter, those depositions.
All right. Any other documents that you've reviewed in preparation for your deposition here today?
No,
Any other documents in your possession regarding this case?
no.
Any notes? Did you make any notes on any of the records or anything like that?
I do my standard, which is I make notes until I talk to my lawyer, and then I get rid of my notes.
Okay. And that's what you did here?
Mm-hmm.
Yes.
Yes, sorry.
And where did you make those notes? And
I just make them on a piece of paper till I talk to them.
all right. And then when did you get rid of those notes?
It's whatever day I talked to her about it, probably was in, I don't know, maybe August.
Okay. And by get rid of them, you mean destroyed them?
Mm-hmm.
Yes?
Yes.
I know we all
I
do
know I
that,
do
but
it.
it's just hard.
I'm sorry. Yes.
So, and why did you destroy your notes regarding this case?
Because my notes tend to be, I'm very detailed. I go through a lot of stuff. I write down a ton of stuff that's not pertinent. And as I form my opinion, there's only a few things in there that are pertinent. And I made a mistake one time of keeping notes and had to sit for 4 hours explaining everything I wrote down. And I decided most of that stuff is nonsense.
Okay.
So, I mean, I write down the gravita and para and all kinds of stuff that really ends up having no bearing in the case whatsoever, but then I have to explain why I wrote it down. So,
Yes, sir. And you don't have any
give it
notes
up.
regarding this case anymore?
No.
True. All right. Unless if you just have a look at page 3 of Exhibit 1, which is the deposition notice. This is all notes, diaries, letters, reports, texts, emails, correspondence, etc. You don't have any documents responsive to that.
I say I have a few emails of setting up the deposition and of them sending the materials to me, but nothing that's going to be remotely interesting. But I guess it would have a few dates, and I can get those.
And you can send that to your lawyer along with what's on
Okay.
this chip number 4, and she can
Okay.
forward that along to
Yeah,
us.
just to be clear, I'm not his lawyer, but he could send
Yeah.
it. He is my
Yeah.
expert, and
Yes.
I will.
All right.
I will get those.
Yeah.
The lawyer that, while she doesn't represent you in this
Yes.
case, she's the lawyer you're working with on this
Yeah.
case, right?
Yes.
Okay. Anything you review to refresh your recollection in paragraph 3 here?
No.
Any other documents consulted, referred to, otherwise used?
No.
Did you refer to any texts, treatises, anything like
No.
that in preparation for your deposition?
No.
All right. Any photographs, videos, recordings, anything like
Other
that?
those x-rays I mentioned, I don't have the disc of.
No
anymore.
photos of the baby though, right?
No.
And Ms. Heather Miller, that's the lawyer that's representing Dr. Onasanya that you're working with here, right?
Yes.
Have you ever worked with her before?
No.
Ever worked
Oh, wait a minute. I worked with Dan McGrew before. I don't remember if
Okay.
you were with
Not
him
me.
then or not.
All right.
Okay.
and you're working with him on this case as well, true?
Well, I mean, I assume they're together, but I haven't talked to him, so
Okay.
I don't know.
All right. You haven't spoken with him about this case?
I don't believe so. No.
All right. And when was the last time you worked with him?
It's got to be a couple of years ago.
A couple of years?
Yeah.
Like 2014 or 15? Or something?
Yes. Well, I don't think 15. I would think
2014?
14, maybe even 13, but
13, 14. And was that on a case in Atlanta?
I don't know.
Okay,
I don't even remember what it was about.
that's fine. Have you worked with any other lawyers in Atlanta?
John Hall's group,
Okay.
and there's another one.
Paul Wethington?
No.
Male, female?
Oh, okay. I mean, it runs together over the years, and I can't remember. I've worked with some. Is there a Greenberg Traurig or something
Yes, sir.
there? Somebody at that firm.
Okay. That was also on behalf of a doctor or a hospital, true?
Yes.
Anyone else?
You know, there may be one other one, but I just blank. Don't know.
All right. Does that Inslee and Race, Kim Woodland, any of that ring a bell?
No,
Okay.
not those.
Ever worked with anyone on behalf of a Tenet hospital? Tenet Healthcare Corp.
Not that I'm aware of, but
Okay.
you know, I usually don't care who the plaintiff or the defendant is, so I
understand.
don't pay that much attention.
All right. Have you ever been to South Fulton Medical Center in Atlanta?
I don't believe so, no.
All right. I'll show you what's been marked as Exhibit 2 to your deposition. This is your disclosure. And have you seen this document before?
No.
All right. You mind taking a moment just to read that?
All right.
All right. This accurately reflects the opinion you plan to offer in this case, true?
Yes.
And if I may just read that, it reads, in pertinent part here, Dr. Coghill will testify that the standard of care does not require a neonatologist to remain at a hospital to care for a paralyzed and ventilated neonate as set forth in Dr. Maraskis' supplemental affidavit and second deposition. True?
Correct.
Any opinions other than that?
Object to form.
You may answer.
Well, I don't really know what the questions are, and since I never received any plaintiff, you know, sometimes they give me the allegations against the defendant,
Yes, sir.
and so I don't know what the allegations are. I know
Okay.
this is one, but I don't know what other allegations there might be.
All right. Well, the defense lawyers are required to let us know what your opinions are so that we can prepare for your deposition. And this is what we were provided. Is this in any way inaccurate or incorrect?
I think the care across the board was excellent.
Okay. Anything else?
No?
All right. And the only criticism you have here is of Dr. Onasanya, true?
Object to
I
form.
don't
He
have
doesn't
a
have any
criticism.
criticisms of Dr. Onasanya.
I'm sorry, the only reference to any criticisms or lack of, go ahead, what'd you say?
Clear my throat. I've got a
All right,
cold.
that's all right. The only person, according to the correspondence, which is Exhibit 2 to your deposition dated August 15, 2006, is your opinion regarding Dr. Onasanya. True? That he did not violate the standard of care. True?
I agree that he did not violate the standard of care.
His care did not fall below the
But
standard of care. True?
I don't know about this, my only opinion,
Okay.
again, and unless, I don't know what questions you're going to ask me,
Okay.
but I didn't find any problems in the care, and I don't have any allegations other than having read in his deposition that this was a criticism. If
Okay.
there are other criticisms, I'm sure I have opinions about them.
Okay. I think you said, I don't want to misquote you, but it was outstanding care across the board, true?
True.
In this case, true?
True.
You feel like Nurse Scott's care was outstanding, true?
I am not a nursing expert and not putting myself out there to be a nursing expert,
Yes, sir.
but I did not find problems in the care.
All right. Same thing for the nurse practitioner, Posley. Outstanding care there as well, true?
True.
Outstanding care by Mr. Blassingame, true?
True.
Outstanding care by Mr. Wright, true? The other respiratory therapist.
Let's just say I found the care to be to meet the standard of care. I
Yes,
don't
sir.
know about using adjectives like outstanding and thing. I felt the care met the standard of care.
Right.
I'm not putting them out as having been better than anyone else.
All right. Well, then I'll see if I can't do a better job with my question. You felt like Miss Scott, Nurse Scott's care was well within the standard of care, true?
I'm not holding myself out as a nursing expert of care,
Yes,
but
sir.
I did not find any problems.
All right. Same for Zadori Blassingame, true? You felt his care was within the standard of care, true?
True.
Same for Anthony Wright, true? Another
True.
respiratory therapist, true?
True.
Same for
With the
Nurse.
same caveat, I'm not a respiratory therapist.
Yes, sir.
And I did not find any problems in their care.
Okay. And thank you. You answered that question. My question's a little different. Nurse O'Gary, you didn't have any issues with her care. You felt like her care was within the standard of care, true?
I don't remember specifically where she was in that chain.
Okay. And Dr. Onasanya's care, you felt his care was well within the standard of care, true?
Yes.
All right. Now, you work here at, this is Children's of Alabama, true?
Yes.
This is a NICU, right?
Yes.
And you call it is it a newborn intensive care unit or neonatal intensive care unit?
Neonatal intensive care unit.
Yes, sir. It's a neonatal intensive care unit. That's a NICU, true?
Yes.
And this is a level 4
Level
NICU?
4.
All right. And the levels are, have you ever seen this guideline for perinatal care?
I have, and many more editions.
Yes, sir. And what the guidelines for perinatal care, it's put out by the American Academy of Pediatrics, true?
Yes.
And you're a member of the American Academy of Pediatrics,
Yes.
true? And what this does, it lays out the roles and requirements for the different levels of NICUs, true?
It lays out guidelines and recommendations.
All right. It lays out guidelines and recommendations for the various levels of NICUs, true?
True.
Including levels 1, 2, 3, and 4, true?
True.
And now, and you've been here for a while, right?
I've been the medical director here since 1998, I think it is, and I've been here since 1990.
Yes, sir. And in your role here as a medical director, you've overseen respiratory therapists like Mr. Blassingame and Mr. Wright, true?
I've worked with them. They don't report to me.
Yes, sir. But as a medical director, if you had an issue with one, that's certainly you would do something about that rather than endanger a patient, true?
Objective form.
Well, I'm trying to answer it honestly, but I don't
Please.
hire them. I don't fire them.
Yes, sir.
I could talk to their superiors if I had a problem, but I'm not their boss.
Understand. Same thing for nurses, right?
Same thing for nurses.
You write what are called orders, right?
Yes.
And then you expect nurses to follow your orders, true?
Yes.
Same thing for respiratory therapists. You actually write respiratory orders also, true?
Well, the nurse practitioners write them. I don't generally write them, but yes.
You've never written a respiratory order or an order for a respiratory therapist?
Not in probably 10 or 15 years.
Okay. The last time you did write one, you expected it to be followed, true?
Yes.
And if a nurse or a respiratory therapist or a nurse practitioner, for that matter, didn't follow your order, you'd be disappointed, true?
Well, it depends on the circumstances, but yes, I mean,
Yeah. I mean, you wouldn't, if it were endangering your patient, you'd certainly do something about it, true?
well, if I felt it endangered my patient or was not an acceptable response, yes.
Your address is accurate on your CV, right?
It should be.
Let's go ahead and
You
we'll
might
mark
wanna
that.
let me see it.
I'm going to show you what's
tell
been
it
marked
is.
as Exhibit 3. This is your resume or curriculum vitae, true?
Correct.
And that's complete and accurate, true?
That's my home address. Oh, it's as complete as I make these things, but I really don't think much of them, so there's lots of stuff that's not in there, but I
Gotcha.
couldn't tell you what all, because I don't even track most of it.
All right. Any articles that you've written regarding the care, like the care in this case?
No.
Okay. Any chapters in any textbooks that you've written that would involve the care, like the care we're talking about in this case?
No.
Any treatises or portion of treatises that would involve care of the nature of the care we're talking about in this case?
No.
What about any peer-reviewed articles regarding the care, like the care we're talking about in this case?
No. I'm a clinician. I'm not a
I understand.
writer.
I just have to
Yeah,
doing my job,
okay.
sir.
Okay.
Any non-peer-reviewed articles regarding the care,
No.
like the care provided in this? Okay. What about? All right. Have you published anything regarding the care, like the care we're talked about here today in this case?
No.
Okay. All right. I believe I asked you about Dr. Lorenz. You did not review his deposition, true?
No. I
Dr.
did not
Lee-
review it.
I'm sorry, I didn't mean to interrupt you.
No, that's okay. I did not review it.
All right, same for Dr. Lee, true?
True. I did not review it.
And you don't know Dr. Lorenz or Dr. Lee, true?
True.
Do you know Dr. Onasanya?
No.
Have you ever spoken with him?
No.
Ever met him?
No.
Okay. And you hadn't met Keandra Williams, right?
No.
You wouldn't know her if she walked in this room.
No.
And you don't know Dr. Marascus?
No.
You don't know of him?
I've said I've heard the name before, but I don't know if perhaps he was a witness in a prior case
Okay.
or if he was because I was at a conference with him or anything.
Right. And you did read the 2 volumes of his deposition?
Yes.
And his affidavit?
I don't know about the affidavit.
Okay. And you disagree with his testimony regarding Dr. Onasanya's care, true?
I do disagree.
Okay. Because he feels like the care was below the standard of care, you think it was well within the standard of care, true?
Correct.
And you've shared with me all the other documents you've reviewed regarding this case, true?
Yes.
All right. Any documents you prepare regarding this case other than the notes that you said you destroyed
No.
some time ago? All right. Have you ever heard of Joe Volpe?
Yes.
Okay. Are you familiar with his book, Neurology of the Newborn?
Yes.
Do you consider that to be an authoritative textbook?
There's no authoritative textbook.
Okay.
There are too many opinions and too many places to go.
All
It's
right.
well written.
Yes,
It's
sir.
a good source,
Okay.
but there are a lot of good sources.
All right. So it's well written and it's a good source, right?
Correct.
Do you rely on it?
Not in general.
Okay. Same. Are you familiar with ACOG publication called entitled Neonatal Encephalopathy?
Yes.
And you consider that well written
It's well written.
and a good source?
It's a good source.
Okay. Have you ever heard of that referred to as the green or now the blue book? Or you just call it ACOG? Okay.
I just call it ACOG, but
What about Stevenson?
everything's online now.
Right.
They're not colors that go with them.
What about Stephen Bennett's fetal and neonatal brain injury? You familiar with that?
No.
What about Avery's diseases of the newborn?
Yes.
And you consider that to be well written and a good source, true?
It's a good source.
And you use that text?
Among many others, I've used it. I can't
Okay.
say I use it regularly or anything.
What other neonatology techs do you use?
Oh, there's Vanneroff and Martin.
All right,
There's,
that was my next one.
yeah, and well, I mean, it was Gordon Avery and Gordon Avery, Mary Ellen Avery's text. There's several atlases and handbooks.
Okay.
There are lots of texts.
All right. Now, Southwood Medical Center, I know you've never been there. Were you aware that that was a 6-bed NICU?
No, I wasn't aware of that, but
Okay. Now, here at Children's of Alabama, it's my understanding this is a 48-bed NICU.
it's a
true?
48-bed NICU. Yes, 48.
Yeah, 48 beds. And you have neonatologists here 24/7, true?
No,
You do not.
no.
How many?
We have them across the street at UAB.
Okay. Same building,
They,
right?
They're our group. We cover both units, but they're not housed here.
Okay. And how long does it take them to go between the two buildings?
5 minutes.
Okay. And that's, they follow the, what do you call it, the breezeway between the two buildings?
Yes.
Okay. They just don't sleep here, they sleep there, right?
They sleep there. That's a 120-bed unit.
Right.
So
Now, is UAB's unit 120 beds on its own, or is that combined with your 48 beds?
that's on their own.
Okay. All right. And the same neonatologists cover both buildings, right?
Yes.
All right. And they are there 24/7, true?
Yes.
And
Now.
I'm sorry?
I mean, now we've been that way, I don't know, 5 or 6 years maybe now.
Okay.
Maybe longer.
And before 5 or 6 years, how was it?
We took off from home.
Okay. And be here at the hospital within what amount of time?
There wasn't any set amount of time.
Okay. Just as quickly as you could get here.
Yeah, which was different for everybody.
Okay. It would vary between what and what, as best as you can estimate.
Executive form.
Anywhere from 5 minutes to 40 minutes.
Okay. And if you, for instance, got a call and you understood the situation, needed someone there in 5 minutes, and it was going to take you 40 minutes to get there, you would have another physician cover the call, true?
Well, we had in-house residents and fellows who would have covered the...
Okay. Maybe I didn't do a good, when you said 5 or 6 years ago, there weren't neonatologists here all the time.
I don't remember when the date was. It all kinds of runs together, but we didn't used to be in-house, and fellows used to cover it at night, and before them, it would just be residents in-house at night. But as their hours got limited, whenever that was, and we started shedding manpower, we had to move attendings in-house.
All right. So when you were saying it wasn't always that way, the 5 or 6 year, I mean, whenever it
Yeah.
was. My point is that even when you didn't have a neonatologist here full-time, you had a neonatologist in training here full-time, true? Either a resident or a fellow.
A resident or a fellow was covering, yes.
Right. Either a pediatric resident that was an aspiring neonatologist
Well,
or a
no,
neonatologist.
they were just a pediatric resident.
Okay.
They weren't, most of them did not go into neonatology.
Okay. They're still doctors, right?
They're doctors.
Okay. Both the residents and the fellows, true?
Yes.
Have you ever, since you've been working here at Children's or at UAB, have you ever not had a doctor? By a doctor, I mean either a resident, a fellow, or a neonatologist here?
And you're just talking about this location,
No,
James?
do you have an objection? Go ahead.
No, I'm sorry, repeat the question.
Do you mind reading that back, please, ma'am?
Question, since you have been working here at Children's or at UAB, have you ever not had a doctor, and by doctor I mean either a resident, a fellow, or a neonatologist here?
they're 5 minutes over in the other building.
Yes, sir.
It's just nurse practitioners here.
Yes, sir.
So there's always been a doctor, resident, or fellow at UAB and Children's.
Yes, sir.
Not our other nurseries, but at these two.
Yes, sir. And by always here, you mean 24/7, true?
Yes.
Okay. And by not at the others, you mean the other, I think, 5 hospitals?
Yes.
Okay. And by the other 5 hospitals, we're not talking about UAB or Children's, true?
Well, one of the hospitals is UAB West or Medical West, whatever they call it now,
Right.
but
Okay.
Yeah.
And is that a level 3 NICU?
no, that's like a level 0.
Okay. Now, of those other 5 hospitals, again, not talking about UAB or Children's, how many of those 5 are level 3 NICUs?
You know, I don't remember when they reclassified which ones were 2Cs and which ones were 3s, but they all ventilate infants.
Okay.
And they all paralyze infants.
Okay. So, well, I mean, it's my understanding that depending on how long they can ventilate a baby, level 2 can't ventilate a baby as long as a level 3 can, true?
Not in Alabama.
What do you mean not in Alabama?
We can ventilate as long as we want to ventilate. There's
In a level 2 NICU?
There are no time limits. Well, they may have reclassified to level 3 when they redid, because it used to be 1, 2, 3, A, B, C, and then they went to 1, 2, 3, 4.
Right.
And, maybe the ones that were 2C at the time or whatever they called it moved up to level 3. I don't know what their official classifications are, but the state handles that. We ventilate and paralyze in all of them.
You agree that we're traveling under a national standard of care, true?
There's a national standard of care, but, across the nation, there are many small ventilating units.
Right. And by small ventilating units, you're talking about level 2.
It may be level 3. It just,
Okay.
Depends on what personnel they have and whether the state certifies them for whatever it is they do.
Okay. All right.
It's not a national organization. You don't have the AAP doesn't determine your level. The state determines your level.
Well, and your state refers to the guidelines for perinatal care put out by the American Academy of Pediatrics, true?
They do, but it's not the AAP that tells you you're level 3. It's the state of Alabama or the state of Georgia or the state of Illinois.
Yes, sir. And the state of Georgia tells you that by telling you you have to comply with the AAP, which is American Academy of Pediatrics, true?
I don't know that they say you have to comply with it. I think they can all set out their own guidelines.
Right.
They do not have to meet these guidelines. They have to meet the state's interpretation of those guidelines,
Okay.
which may not be the same from state to state.
Did you review the Georgia state interpretation of these guidelines?
No.
Okay. Why not?
I don't see what that has to do with whether I thought they could ventilate. I thought they had the personnel that could do the job, and it's similar to the personnel we use to do the same job. And if they had their certification from the state of Georgia, then they had it.
Okay. So you don't need to look at that to make a determination about whether Dr. Onasanya complied with the standard of care here, true?
True.
Okay. Have you ever worked in a level 3 NICU that did not have a doctor there 24/7? And by doctor, I mean, again, either a neonatologist
Yes.
or a resident or a fellow?
Yes.
Okay. How long ago was that?
I still work in one.
Okay. Which one is that?
Grandview Medical Center.
And that's a level 3?
Yes.
Okay. Any
And
others?
then the other ones here, I mean, there are others here in the city that we don't cover, but that are also level 3 that.
Okay. All right. Any others that you cover?
again, I don't know the exactness of what the state calls them, whether they call them level 3 or not, but we ventilate and paralyze at Baptist Medical Center Princeton, at Baptist Medical Center Shelby, and at St. Vincent's East.
Okay. Paralyze and ventilate. That means you use a paralytic to paralyze the baby, and then
Yes.
by ventilator you mean a breathing machine. The machine
Yes.
breathing for the baby. True?
Yes.
All right. You agree that Caden Henderson was critically ill, true?
True.
Suffering from what's known as respiratory distress syndrome, true?
True.
And he was also intubated, true?
True.
Being ventilated, true?
True.
And by ventilated, we mean he was on a breathing machine, true?
True.
Now, you can't, if your musculature, your chest cavity is paralyzed, you can't breathe, true?
Well, it depends on the depth of paralyzation, but if you're fully paralyzed, you can't breathe.
Okay, because the way you breathe is to expand your chest and then the air comes in, true?
True.
And when baby Caden was paralyzed, he couldn't do that, right?
If it's paralyzed that deeply, but most of the time they're not that deep.
Any reason to believe he was not paralyzed that deeply?
Well, in general, they were dosing the paralyzing agent as needed, which means you only know it's needed when he starts to wake up and move. So
Okay.
if he's able to wake up and move for you to know he needs more paralytic, then he's able to breathe some too.
Okay. So is it your testimony that Caden could have breathed on his own?
Well, I don't know that he could breathe on his own. I would think the intention was it wouldn't be very good if he could breathe on his own, that you were trying to keep him paralyzed. That was
Right.
your object.
And that's why you, in concert with the paralytic, use the ventilator so that the machine's doing the breathing for him, true?
The machine is doing the breathing for him.
Now, when you've got a critically ill baby that's paralyzed by a physician and on a breathing machine and an epidrip like this baby, Dr. Onasanya had a number of choices, true?
What do you mean he had a number of
Well,
choices?
Dr. Onasanya could have stayed with the baby, true?
Yes.
He could have had another doctor, either a resident or a fellow or neonatologist stay with the baby, true?
Yes.
He also could have transferred that baby to Children's Healthcare of Atlanta, true?
Yes.
And are you aware that Children's Healthcare of Atlanta from Southwood Medical Center is probably 20 minutes away?
No, but I mean, they're in Atlanta,
No,
so
they're-
they're not too far.
Yes, sir. Is Children's Alabama in any way affiliated with Children's Healthcare of Atlanta?
No.
Okay, just they have the same
Yeah.
one word in the name. Got
Yeah.
it. All right. Now, and you paralyze babies, true?
Not frequently, but
Okay.
yes, we do.
When was the last time you paralyzed a baby like Caden?
Oh, last month.
Okay, a month ago? About how many times have you done it this year?
Oh, a lot.
Okay.
I don't know.
And
10,
that-
20 times.
Okay. And that's for babies that have RDS, respiratory distress syndrome?
Sometimes RDS, sometimes it's pulmonary hypertension.
Okay.
Sometimes it's bad chronic lung disease.
Okay. Now, baby Caden did not have a chronic lung disease, true?
Wasn't old enough.
Right.
Did not have one.
That would take weeks,
Yes.
right? And what Dr. Onasanya did was leave a critically ill baby that was intubated on a ventilator where the machine was doing the breathing for him, also on an epidrip there at Southwood Medical Center with a nurse practitioner and a respiratory therapist and a nurse, true?
True.
And you saw in the record where Dr. Onasanya initially intubated baby Caden, true?
I don't remember. I don't
Okay.
remember who did the initial intubation. I don't believe he did the second intubation.
You don't believe he did? You recall him doing the initial intubation?
No,
but
I
not
don't
this?
recall who did the initial one, but I don't believe he did the second one. I think that was Blassingame. And the third one was Blassingame, I believe.
On what dates were the second and third one, if you remember?
He was intubated, and then, as I recall, they had tried to extubate him. Oh, no, they didn't get him extubated. That's right. They didn't quite get it. They were going to extubate him, but he worked too hard to breathe, and she decided not to do it.
Right. Have you
Yeah,
ever
he did the
had
second
a baby that you paralyzed self-extubate or pull his tube out?
Yeah.
Okay. How many times does that happen?
Well, it depends on how deeply you're paralyzing them. The paralytic agents we use today are not quite as powerful or effective as the paralytic agents we used 10 years ago. And the ones 10 years ago would leave the kid really totally paralyzed. The ones that we use now, they're constantly waking up, and they can slime that tube out with their tongue and saliva. They can actually pull it out with a hand, or sometimes it could get dislodged by the healthcare team. But in just moving the patient, weighing them, bathing them, whatever else it is you do.
Okay. And what about the ones you used 5 years ago?
Well, that's about the time that Pavulon ended up in short supply and you couldn't use it. So, we had moved away from what I call the real paralytics to the ones that, the kids are often moving around some on these.
Okay.
The rocuroniums and the other.
Well, rocuronium, you think that's one of the real paralytics?
No.
Okay.
No,
That's not a real
sure.
paralytic.
It's a paralytic, but it doesn't, when you dose them, it's shorter acting than Pavulon, which was a very long acting one. And you're often having to redose them because they start moving again. Okay. So the cisatricurium, the rocuroniums, our kids, we just don't take to as deep a level as we did with the pancuronium.
Did you see anywhere, I didn't see anywhere in the record where the paralytic wasn't working and the baby was moving around. Did you see anything like that in this case?
No.
Okay. I'll show you what's been marked as SFMCKH0028, which appears to be the intubation of the baby, endotracheal intubation, and it appears to me that that was Dr. Onasanya. Does that refresh your recollection about that? Who intubated the baby initially?
It says he dictated the note.
Yes, sir.
I don't know that note tells me who actually did the procedure.
Okay. Well, it's... Okay. It doesn't have the name of anybody else doing the... It reads procedure, endotracheal intubation, then it's got his signature, right? Or
I
his
just know we do procedure notes all the time for lines and placement, and the practitioner may be the one putting the line in, and I'm over there writing the note about it, and we're both there together, and if I dictated it, it's going to put my name on it, and I may not have put their name in it.
All right.
So I don't know. I assume from reading it, my assumption would be he did it, but I don't know that.
Any reason to believe that Dr. Onasanya would not have been able to successfully intubate Caden Henderson?
Objective form.
Well, all children can be difficult to intubate, and I mean, we have children here who end up with tracheostomies because they couldn't be intubated by anybody. So, I don't know. I mean, without having tried to intubate this child, I couldn't tell you how easy or difficult it is.
Okay. If you had a baby that needed intubating and you had a choice between a board-certified neonatologist or a neonatal fellow or a resident or a nurse practitioner or a nurse or a respiratory therapist, they're all standing right there, which one are you going to choose?
Go with the people who have experience doing it. And for us here, it would be, in general, the nurse practitioner would do the best job because they get the most attempts.
Okay. And those are experienced nurse practitioners?
They're experienced nurse practitioners.
How experienced?
I mean, I'm not going to admit any of them are better than I am, but I'm just going to tell you that they are quite skilled, and I do not bump them out of the way ever.
Okay. But as far as, well, so not better than you are, in other words...
well, that's
you
my
would,
ego.
me,
That's not true.
I know, but let me finish. Not better than you are, you would be able to successfully intubate a baby. True?
Objectify, it's a compound question.
I would like to think I could intubate anyone, but I know that's not true because I know there's been at least one I could not intubate, and I know there's one in this nursery right now I cannot intubate.
Okay. 1 in 30 years? Is that?
Well, you know, I don't know about all those the practitioners intubated. I didn't have to try any of those.
Okay.
But I mean, we leave practitioners to do that, and they do the vast majority of intubations.
All right. And how much experience do your nurse practitioners here have?
Oh, it depends on how long they've been around, but a lot of them have been here 20 and 30 years.
Okay. Do you know how much experience nurse practitioner Posley had?
Well, I know she was like a year and a half or something out of her training, but she'd been a nurse a long time, and I don't know what her extent of training was.
You have nurses intubate babies here?
We did up until about 95 or so when the Board of Nursing changed what they were licensed to do.
Okay. In this case, it's 2011, right?
Yes.
Okay. You didn't have any nurses intubating babies here in 2011, true?
Nurse practitioners, but not staff
Right.
nurses.
Nurse practitioners, but not nurses, true?
Correct.
Okay. And did you have any nurse practitioners with 11 months experience intubating babies here?
Oh, yeah.
Okay. Now, you looked at this code, right? And we'll get into it in a moment, right?
Yes.
But it wasn't the nurse practitioner that was intubating the baby, it was a respiratory therapist, true?
True.
Okay. So we had the respiratory therapist running this code, not the nurse practitioner.
Yeah, the respiratory therapist do the intubation. I don't know that they ran the code.
There was nothing more important than getting an airway for that baby in that code, true?
Correct.
Now, if I'm going to ask you what's called a hypothetical question, and it's my job to prove these facts at trial, but for the purposes of the question, you have to assume that the facts are true, all right?
Okay.
I want you to assume that you have a baby that is suffering from respiratory distress syndrome, all right? And that a physician's used a paralytic on that baby, and that baby is intubated and breathing through a breathing machine, a ventilator, and that that baby is also receiving an epi-drip, and that baby's in a level 3 NICU. Would you rather that baby to be present for that baby a board-certified neonatologist or a fellow, a neonatology fellow in training, or a resident, or a nurse practitioner, or a nurse, or respiratory therapist?
Check the form. I believe he's asked and that's been asked and answered,
Well,
but you can
I
answer,
am-
Dr. Coghill.
Perfectly comfortable with a nurse practitioner taking care of the child, and it's usually a team of people, but
Yes, sir.
we use nurse practitioners. Some people use physician's assistants. Some people use respiratory to intubate, but I wouldn't be comfortable with just respiratory being there.
Yes, sir.
So,
Okay. But given a choice between a neonatologist and a nurse practitioner, you'd rather have the nurse practitioner intubating
I wouldn't
the baby?
rather have. I would take either one.
Okay. So you're indifferent to either of those two, true?
True.
Now I want you to assume for the moment that you have a choice between a board-certified neonatologist and a nurse practitioner with 11 months experience.
I have perfectly good nurse practitioners with 11 months experience who I would be very comfortable with.
Yes, sir. My question's a little different, though. You would be indifferent to either of those two running a code like this and intubating the baby, true?
I think true. I think
Okay.
we've trained them well, and I'm perfectly comfortable with them running through their training.
Okay. And same for a respiratory therapist, you would be indifferent to a board-certified neonatologist or a nurse practitioner with 11 months experience or a respiratory therapist intubating this baby, true?
I'm comfortable with whoever has the experience and the skills to do it.
Okay, and thank you, answered that question. My question was a little different, though. Do you mind reading back my question, please, ma'am?
Question, in the same for the respiratory therapist, you would be indifferent to a board-certified neonatologist, a nurse practitioner with 11 months experience, or a resident, or a respiratory therapist intubating this baby.
I have a problem with the word indifferent, as though I don't care.
Yes, sir.
I care about who's doing the intubation, that they have the skills to do it.
Right.
I believe that you can teach a wide variety of people the skills necessary to do that, and that there is nothing that I, as a neonatologist, should have any better chance of intubating than someone else I've taught. No more than I could ride a bike better than they could.
Okay. So it's about like riding a bike to you.
Objective.
No, it's a high-skilled operation, but it's not something that I can't teach them. We teach them to do IVs. We teach them to do central PIC lines. That requires a high level of skill, and yet they're much better than almost every one of the neonatologists on our staff.
At intubating a baby.
I would say at intubating a baby, they're at least as good as half of the physicians on staff. So if
Okay.
you're looking at average, yeah, they're there.
All right. Now, you saw the code sheet, right?
Yes.
In this case. You saw that albuterol was administered
Yes.
and calcium was administered. You would have administered albuterol and calcium, just like was done here, true?
I rarely use albuterol, and I might have used a dose of calcium. I probably wouldn't have given 5 or 6 doses or whatever it was.
Okay. And that's because the NRP actually says you don't do that, true?
Well, the it's not part of the recommended part of NRP. It's
Right.
not a standard step. However, when the heart's failing, it is a common step that people will use.
So
But I don't think it was likely to help this baby. I don't
Right.
think it was likely to hurt this baby, but if it's not going to help them, it's a bit of a waste of time.
Right, and you agree that with this code, time was of the essence, true?
Well, I don't think they're giving calcium had anything to do with delaying anything else, but that wasn't going to help them.
Right, same for the albuterol, true?
Well, the albuterol has I mean, you know, if you think this kid has some kind of bronchospastic event, and occasionally, you know, if you hear a wheeze or you think they're really clamped down, I wouldn't object to albuterol. But again, it's not something I do routinely.
Do you think Caden was suffering from a bronchospasm?
I think he probably had a mucus plug as part of it. I don't think he really had a bronchospasm, but I can't say with 100% certainty he did not.
You agree that this baby did not have BPD, true?
I wasn't old enough to have BPD.
Right. In fact, to have BPT, you would have to be an extremely premature infant.
Well, you have to be 28 days old.
Right.
So he's
And on
never
ventilation
didn't
for
get
10 to
there.
14, right? All right. And tell me, so the baby was suffering from RDS, true? Respiratory distress syndrome, true?
Well, he suffered from it the first 3 days of his life. I don't
Right.
think at the time he deteriorated that was the cause.
On the 12th, Dr. Onasanya testified on the 12th he was actually getting better before this could
Yes.
happen, true?
Yes,
And he was not suffering from BPD, true?
true.
And that's dysplasia, right?
Bronchopulmonary dysplasia.
Caden was never suffering from bronchopulmonary dysplasia, true?
Well, you don't know that wouldn't have formed. I mean, that's why you have to wait 28 days and see if they still require oxygen. But he wasn't old enough to say he was suffering from bronchopulmonary dysplasia.
Right. So the answer is he was not suffering from bronchopulmonary dysplasia, true?
I'm not trying to avoid your question, but bronchopulmonary dysplasia, you can't lay that diagnosis on until they're 28 days.
Right.
But for the kids who subsequently develop it, they're developing it from the start. It's
Okay.
the scarring is already going on. So I don't know if he had bronchopulmonary dysplastic changes going on until he's 28 days old. So he might have had it developing, he might not have had it developing.
But he didn't have it because he wasn't 28 days old when he died, true?
He can't be labeled with the diagnosis until he is 28 days old.
Okay. All right. You agree that a level 3 NICU requires continuous coverage by neonatologists, true?
Check the form.
It requires that a neonatologist is available 24 hours a day.
Yes, sir. And a single neonatologist cannot provide 24-hour coverage 7 days a week, every single day, true?
It depends on how busy your unit is. I mean, you can provide 24/7 if you're sleeping every night on call and you're not actually going into the hospital, but if you were having to go in a lot, you would wear out. I don't think you could do it. But most of the time, people who are in small practices, and I've covered for people who do that, and we're a single person doing a unit long term, and we would cover them a weekend and a week every now and then, but they were pretty much doing every day.
A single person, 24 hours a day, 7 days a week with no backup, right?
That's right.
And you have that at the hospitals where you work here now?
No.
Okay. Why is that?
Well, because we're a big group, we cover each other.
Right.
But when Huntsville got started, their neonatologist was one guy.
Yeah, okay. With no backup.
With no backup other than to calling us in Birmingham to drive up there and help him out if we needed to.
Right. That's something called regionalization. Have you ever heard that word?
Sure.
And regionalization means NICUs like yours, Children's of Alabama and UAB, in these two adjacent buildings, and Children's Healthcare of Atlanta, those are regional centers, true?
True.
And for someone like you mentioned, a guy that's trying to cover a small NICU all on his own, if he has an
His
issue.
wasn't small,
Okay.
so it was large, and
Okay.
it's a regional center.
All right. If he's trying to cover a NICU on his own, and he runs into some trouble, he can either transfer that baby here or call you or one of your colleagues. True?
True.
Okay. And that's what this guy did when he got into if he needed help, right?
I don't know what he did.
Well, I thought you said he called. He'd
Oh,
called.
you mean the guy in Huntsville?
right.
Yes, I thought you
Okay.
meant Dr. Onasanya.
No. Well, Dr. Onasanya,
I don't know what his coverage arrangements were.
you read the depositions, right?
I've read the depositions.
He was the only neonatologist, and he didn't have any backup.
No, I knew he was only a neonatologist, but I didn't know if he had a locum tenens group that covered him for vacations or what. I assume he took some vacations, so he must have had some arrangements.
Yeah. And you didn't see that, though? in the
No.
record. Okay. Let's see. Let's finish this. Your CV, you mind having a look at that? That's Exhibit 3, right?
Yes.
This 1998 to present, hospital appointments, medical director, newborn intensive care unit. That's a level 4, 48 beds, and there are 24/7 neonatologists there in the building next door because they're housed at UAB, right?
Yes.
But they work both units, right?
Yes.
You got here something.
Now, it wasn't always 48 beds. It's 48 beds now.
Right.
So it's grown a lot.
Well, and there are 120 beds in
Yes.
the same complex here, right?
Yes.
And then it says physician champion high reliability unit, right?
Yes.
What is that?
Oh, garbage title.
What?
It's a garbage title. It's it's high reliability unit projects like modeling airplane industry stuff for trying to improve patient care. And we have little huddles, and we go through a board, and we talk about the problems that we have and what needs attention, and you give some data and feedback to people so that they see that what they do makes a difference. But as far as a title, it's just what I do every day.
Gotcha.
Somebody put a title on it.
Okay. Physician champion. And I'm looking at your board certified. You're board certified in neonatology, true?
Yes.
I'm sorry, board certified in pediatrics, subboarded in neonatology, true?
Yes.
Then it's got recertified 2010, completed first cycle 2015, currently satisfying all MOC requirements. What does that
Yeah.
mean?
They went away from the every 10-year or 7-year exam, and they have what they call maintenance of certification, which is a bunch of modules you work through, and it's still an exam every 10 years. But they're changing it again, I think, this year. So whatever they have for certification, I've done.
Okay. Then you teach CRNP students, is that right?
Yes.
And those are nurse practitioners?
Yes.
Okay. And you've been doing that since 2000?
I've been doing that since 1988, but as part of what I do here through this program.
Now, you didn't
2000.
teach Miss Posley?
It's possible if she did a rotation here, but I don't remember her, and I don't really have any records that would tell me that, but I assume that South Alabama would know whether she did a rotation in this unit. But that doesn't mean I would have taught her. If she was one of the months I wasn't here, she would have had somebody else.
According to the medical record here, she didn't make any attempts to intubate the baby, true?
I didn't see any in the medical record.
It was all the two respiratory therapists, Mr. Wright and Mr. Bossingame, true?
Blessing game.
No one else.
No one else that I'm aware of.
And I looked at your your published manuscripts you've got here, these are on pages 5 and 6, right?
Five and six, yes.
And none of these deal with the issues in this case, true?
Oh, I mean, there's ventilation, but none of it deals with paralyzation or physician coverage.
Okay. Ventilation, and this is your new therapies for neonatal respiratory failure. You wrote, or you were one of, I think, 3 co-authors on
I
the
wrote
chapter.
the chapter on high frequency.
Okay, and that was 1994, is that right?
Oh, I can't tell you what year it is. Yes, whatever year. It's 96, it looks like.
Okay. All right. Okay. You agree it's never all right to needlessly endanger your patient, true?
No one would needlessly endanger anyone.
And thank you.
Yes.
That's a little different. Though. You agree it's
I
never
agree.
all right.
Never all right to needlessly endanger my patient.
Right. And you agree that the safety of your patient is paramount importance, true?
True.
Okay. And you agree that it's important as a doctor to do what's in the best interest of your patient, true?
True.
To, as best as you can, ensure your patient's safety and well-being, true?
True.
And that would include a critically ill baby like Caden, true?
True.
Okay. Include a critically ill baby that had been paralyzed by a physician and was on a ventilator or breathing machine, true?
True.
You, there was a code in this case, true?
True.
And it began at 12:50 in the morning, true? You want
would
a
have
copy of
look
this?
to say
I think I have
exactly,
another
but yes.
copy.
But that sounds correct.
Well, but let
yes.
me, so I got another copy here. You want to make a copy?
I can probably do that. Just this one sheet?
Oh, no, all 3 of these are the back, but if you can just make, I guess, a couple of copies, we can.
A couple as in 2 or a couple as in
Well,
3?
one for the court reporter, one for you. I can use that one. Do you want one?
I'll be good.
2's good. Thank you.
We are off the record at, sorry, we are off the record at 6:45 p.m.
Sir?
This marks the beginning.
Check
We'll see
mark.
those
This marks the
left-handed check
beginning of
marks.
Disc 2. We are back on the record at 6:48 p.m.
All right. Doctor, I'll show you what's been marked as Plaintiff's Exhibit 5. This is the code sheet, which goes from SFMC KH0345 to 0349, true?
Yes.
And the the code was on November 13, 2011, true?
Yes,
It started at 0050, that's 12:50 in the morning.
yes,
And it ended at 1:43 that morning, true?
yes,
So it's a total of 53 minutes.
yes.
And when the code started, the baby was not breathing, true?
No check for spontaneous breathing, so true.
Well, we can start up here. If you look at condition of patient apneic, do you see that?
Yes,
Which indicates that the baby's not breathing, true?
yes,
It also indicates that the baby's unconscious, true?
I'm sorry, I don't see.
See
where
right
they
here where
put
it says was maybe
conscious.
conscious at onset? That
Box is checked, no, true.
No, okay, that's checked, yes,
And it also, the baby's cyanotic, which is,
yes,
means the baby's blue, right?
yes,
And there's also sustained bradycardia, less than 80, true?
yes,
And by bradycardia, that's a baby's heart rate, depending, here below 110, true?
well, I mean, this check mark says below 80.
Right, it reads here sustained bradycardia less than 80, true?
True,
And the baby's got a 4.0 ET tube, true?
true,
That's an endotracheal tube, true?
true.
And an endotracheal tube is used to do what?
For the ventilation, breathe for him,
To oxygenate the baby.
it's part of it, yes,
And reads the first assisted ventilation was at 0050, true?
Where did that-
Sorry.
Well, he was on the ventilator before the whole thing started, and then he's bagged starting, I guess he's extubated and bagged at 0050. That's the
Right.
time of first.
Now, Caden Henderson, he was born on November the 8th, 2011, true?
Yes.
Gestational age was 37 weeks, 4 days,
4
true?
days, yes.
He was a full-term baby, right?
Yes.
Beyond 37 weeks is considered a term baby, true?
Yes, there's some debate about that these days, but yes.
Right, they came out with a new phrase, I think it's called near term, or what is it?
Yeah, early
Early
term.
Right. But still considered a term baby, true?
Yes,
And his APGARs were 8 and 9, true?
correct.
He was born at 13:05, that's 1:05 in the afternoon, right?
I don't remember the time, but yes, something close.
And about an hour after delivery, according to the medical record, he had increased WOB, which means work of
Work of
breathing,
breathing.
true?
True.
And had some, I think, grunting, they wrote, right?
I don't recall, but yes, he had symptoms of respiratory distress.
Okay. Syndrome, RDS, right?
Well, he had respiratory distress. The syndrome part you kind of diagnose by how he responds
Okay.
and how long it lasts.
And because this lasted more than a couple days, you would consider this atypical RDS, true?
No, I think he had typical RDS.
Okay, typical RDS. So it was just taking a little bit longer to get him going.
Well, I mean, the normal course of RDS is to slowly work, outside of the use of surfactant, is to slowly worsen for approximately 3 to 3.5 days and then to get rapidly better.
Okay, so this is typical RDS, true?
It's typical, atypical from the standpoint of it occurred at 37 weeks, but
Right.
typical for the course of RDS.
Typically occurs in a preterm baby, true?
Well, the earlier you're born, the higher the risk, but
Right.
it still occurs even at term.
And in a case like this, when you have a diabetic mother, the incidence is what, 5%, something like that?
Yeah, maybe 5%.
Okay. And then on the 12th, as Dr. Onasanya testified, he was getting better, which indicated to you, I think you said, the way he reacts to the treatment indicates
Suggests
it's
that it was RDS that
typical RDS.
was getting better. Yes.
All right. And then back to this code sheet at 0345, the total code was about 53 minutes, is that right?
Yes.
And looks like his heart, the baby's heart was stopped from 0100 to 0120, true?
I'm trying to see where they put heart rates in here.
Let's see.
See the spontaneous pulse here.
Spontaneous, so stopped from 058 or 6. I can't tell what that number is.
Yeah, the last heartbeat's at 058, right?
058 until 0120.
Okay. So that's a total of between 20 and 22 minutes, something like that.
Yes, now this says pulse, so I don't know. A lot of times the 0 is because you're doing chest compressions, and I don't know that that there was no spontaneous beating because the monitor is, you can't see anything unless you stop the compression. So until you feel like the heart rate has come back up to a reasonable amount, you don't generally stop just to find out it's still 20.
Okay.
So I don't know that 0 is appropriate, but once you start the compressions, the pulse should be whatever rate you're doing the compressions at, because that is, you should be able to feel the pulse if you're doing it that way. But I suspect they're looking at the monitor, which now is just whatever they're pumping with their hands, and so since they're pumping with their hands, they call it 0.
Well, now, I mean, they testified that the baby's heart stopped. You read that, right?
Yes,
Okay,
that it
you-
stopped, but I don't think they independently at each of these minutes stopped to look and see if maybe there were a few beats here and there. It's trivial. It doesn't matter. From your standpoint, the heart rate was not sufficient for
Right.
that period of time.
And the heart rate, even before it stopped, well, between 0058 and 0100, it was 48, 50, 46, 44, 44, 40. True?
Yes,
All well below 80. True?
yes,
And not sufficient to oxygenate the baby or keep the baby alive. True?
likely insufficient. Keeping them alive is a different story, but not adequate.
Right. Well, you're aware of studies that if you deprive your brain of, or severely limit the amount of oxygenated blood to your brain, in about 12 minutes, you start to get irreversible brain damage. True?
It's varied by so many factors that I wouldn't put a time on it.
Okay.
And infants have unusual ability to recover from those things.
Okay. And do you agree that after 18 or 20 minutes that typically it would result in brain death?
No.
Okay.
It's very variable. It depends on, did you have some perfusion, even if you were doing it with CPR?
Right.
Did you have perfusion of the blood to the brain? Did you have some oxygenation of the brain? Remember, inside mom, this baby got very little oxygen. Not something you or I could tolerate.
Right.
But how long you might last and where you might go, they're not ideal circumstances. That's not where I want them to be. But I can't tell you 12 minutes, 18 minutes. We've coded kids for an hour and had them turn out well. do well. We had one just this year who coded for 45 minutes in the OR who did well. As far as we know, he's not old enough now to know that he doesn't have some damage, but he went home eating and doing everything we would expect a baby to do. So obviously there's a lot we don't know about that.
Right. By some damage, you're talking about brain damage, right?
Yes.
Okay. Have you ever heard of Manual of Neonatal Intensive Care by Janet Rennie and Giles Kendall?
I don't know this particular reference, no.
Okay. There's a discussion on page 38 about the physiology of neonatal resuscitation. Do you see that?
Yes.
And it, down here, the last paragraph on that page, animal studies demonstrate that it's possible to survive for more than 20 minutes of complete asphyxia. Do you see that?
I'm sorry, you're going to have to show me where you're reading that.
Yeah, it's just the start of that paragraph.
Oh. Okay.
If you look at the fifth line, they're referring to Joe Volpe's textbook.
Yes, I don't know if that's his textbook, but something he wrote in 2008. I don't have all the
It says brain
references.
damage affecting primarily the basal ganglia and brainstem appears within 10 to 12 minutes. Would you agree with that?
Oh, it can appear within 10 to 12 minutes. I don't
Okay.
believe it always appears, and I don't believe that any two asphyxias are exactly alike.
Okay.
I mean, you can ligate the vessels so that there's no blood going to the brain, and you can measure how long things will last. But that's not usually what's happening. You're doing CPR, there's some blood getting there. Is it enough? Is it not enough? How long has it been? Are you getting oxygen in there? There's so many variables. It's not like it's complete lack, which is usually what you do in animal studies.
Right.
There's some there. And is it just a little? Is it a moderate amount? Is it a lot? And the kids who do well, it's probably because they got very effective chest compressions. They never lost perfusion, and they ended up doing pretty well. Okay. So I can't, you know, and sometimes the only way you know that is by how well the child turns out.
Okay. Now, Caden did not turn out well, true?
True.
He died.
Yes.
They took him off life support a couple days after this, true?
They did.
And you agree that the brain damage that he suffered was as a result of this 53-minute code, true?
Yes, I think so.
Okay. I mean, when he was born, his APGARs were 8 and 9, and right?
Yes, he had some worrisome things in his prenatal history, but not anything that makes me think that was the cause.
Any cause other than the 53-minute code, true?
True.
And as a result of the code, well, after the code, his body was working again, but he'd been deprived, his brain had been deprived of oxygen for too long, and his brain died, true?
I don't know about the brain died thing, but he had significant brain damage, enough that the family and the doctors chose to withdraw support.
Right. You didn't look at those films, you just read the reports, right?
Correct.
And you
But
said
brain death requires, there is no brain death criteria in neonates.
Okay.
So you can't really say a neonate has brain death.
Okay, so, but it was, you agree that it was brain damage significant
Severe
enough
brain
to-
damage
I mean,
enough. Yeah, okay.
It was brain damage significant enough that they had to withdraw life support, true?
They chose to withdraw life support. They didn't have to withdraw life support.
Do you think that Caden would have done well if they had chosen not to withdraw life support?
No, I think he was very high risk to be severely handicapped and or progress to die from his illness.
Right.
But would he have died? I don't know that.
And by his illness, you're talking about the damage to his
The brain damage, yes.
Brain damage thing. And if we look at, I mean, this is a certified copy of the medical record, true? That's what you reviewed, right? This is a portion of what you reviewed.
Yes.
Any reason to believe that it's been doctored, altered, inaccurate in any way?
No.
Okay. It reads here that Dr. Onasanya was notified by the nurse practitioner at 0050, true?
That's what it says.
And he arrived half an hour later, right?
That's what the note says.
At 1:20. Any reason to believe that note is inaccurate?
Well, you know, this is when the person who wrote this recorded that he was there. That he might have been there earlier and they didn't see him, or that he was observing from somewhere, I have no idea. But from this person's perspective, I have no reason to believe they didn't record what they saw.
Yes, sir. And if you look at the pulse ox over on the left, what number would you like to see in that first column?
Pulse ox, I mean, in the midst of a code, I'd love to see it 80 to even 100, but I don't really want 100, but certainly more than 80, preferably in the 90s.
Now, and my question, that's in the midst of a code. What about not in the midst
Generally,
of a code?
the targets most people use these days are 90 to 95. Some people use 88 to 95.
Okay. And these numbers are significantly less than 88 to 95 up until, looks like 137 that morning, true?
Yes.
Okay. And then as far as the spontaneous pulse, you would want to see his heart rate at what, ideally?
Well, I don't know. There's no spontaneous pulse. They're doing chest compressions. If they're doing them and they're effective, then they're doing them at a rate of about 90 a minute.
Okay. If they weren't doing chest compressions, what would you want his heart rate to be?
80 to 180.
Okay. Anywhere from 80 to 180 would be okay with you.
Yeah, depending on the kid and whether they're asleep, awake, what their needs are, but yes.
All right.
I mean, that's where your monitor limits are set in general.
All right. And here's, we've got the epinephrine. You don't have any issues with administering epinephrine?
No.
Okay. We've also, they're administering, it's called the volume expander here, is that right? You see where it reads calcium gluconate?
Glasses. I see calcium gluconate.
Right. Is that a volume expander?
That's calcium.
Okay.
It does happen because of the strength it has to be. You end up giving a fair amount of volume, but
Okay.
its primary use is to give the calcium for the heart contractility.
Right. And you don't believe that was contraindicated here, true?
I don't think it was contraindicated. I don't know that it was necessarily needed, but a sick heart that's had acidosis, I don't object to them having given calcium.
Okay. And you don't object to them having given 6 doses, right?
I wouldn't have given 6 doses. I don't know what they were trying to do with that, but I don't think it had any real relevance to what went on.
And why wouldn't you have given 6 doses?
Because I don't think it's going to help. I don't think it's a lack of calcium that's the problem.
The problem was the airway, true?
The problem was the airway and or the lungs.
And the albuterol, I think you've already testified that you would not have given albuterol here. Is that right?
Occasionally we give albuterol if we think they're bronchospastic. This is not the typical kid I would think of to be bronchospastic, so I probably would not have thought to give this child albuterol. Again, I don't think it was wrong. I just don't think that was going to make a difference.
It was because he was not bronchospastic, true?
I don't think he was bronchospastic just because of his age and size, but
Right.
if I had been there and heard him wheezing or I thought that the air wasn't getting out, I wouldn't have been adverse if my respiratory therapist had suggested it to say, and go ahead and try it.
And you agree that baby Caden was not suffering from a pneumothorax, true?
True.
And you saw that in Dr. Onasanya's note, and you agree that's an error?
I saw the x-rays and I didn't see anything I thought was a pneumothorax.
Right. And it reads here that they drew venous blood gases. Is that right?
Yes,
And did you look at those blood gases?
I did.
And I'm looking at, for the record, SFMC KH0213, which looks like, according to the record, the first blood gas after the code. And it's got the PO2, that's the patient's oxygen, right?
Yes,
And it's got 135.2, do you see that?
yes.
Do you believe that to be a correct?
What time is this gas from?
220?
Yes.
Okay. And why would it be 135?
I assume he's on 100% oxygen and had been ventilated.
And, but it doesn't say 100, it says 135.
Well, that's just the partial pressure of
Right.
oxygen in the blood, and it's a venous sample, so his lungs are working. He's got plenty of oxygen. His arterial PO2 is probably in the 400s.
Okay.
His venous PO2, which would normally be somewhere in the 40 or something, is going to be high because he's on a lot of
Give it
oxygen.
Okay, all right. Some of these. You agree that code caused his brain injury, true?
I believe that's true.
I'll show you what's been marked as Exhibit 7 to your deposition. This is, let me give you one. This is the guidelines for perinatal care. Pages 14 and 15. You ever seen that document before? This is part of the, get that.
I'm sure I've probably read it before, but I haven't seen it recently.
All right, that's good. If you look, this this is the American Academy of Pediatrics, of which you're a member, true?
Yes,
And also the American College of Obstetricians and Gynecologists. You're not a member of that college, true?
True.
You're not a just because you're not a gynecologist, right?
right.
And it reads here, guidelines for perinatal care, true, at the top of the page, 14.
Yes.
And if you look under level 3 neonatal care, which is, that's the level that South Medical Center was when Caden was there, true?
I'm sorry, what?
That's the level that the South Medical Center, the hospital we're talking about when Caden was there.
Level
when this
3.
code, true?
Yes.
And it reads here, beginning with clinical experience. You see that? Let's see, right here.
Okay.
Designation of level 3 care should be based on clinical experience as demonstrated by large patient volume, increasing complexity of care, and availability of pediatric medical subspecialists. Sure, you see that?
Yes.
You agree with that, right?
I'm not sure I agree with the whole level of care designation stuff. I think that across the country, These levels don't apply to many, many nurseries. There's all kinds of conglomerations of what people are present and available immediately in-house, telemedicine, consultation on the telephone. There are all kinds of ways people say they have these people present. And so I don't know, even our own nurseries are varied in which subspecialists come, which ones don't, who's available by phone. So I don't know.
All right. So you don't necessarily agree with this, true?
I don't necessarily agree with it as written, no.
Okay. And if you look down just a little bit more where it reads, I think level 3 here. Level 3 neonatal intensive care units, parenthetically NICUs, you see that?
Yes.
Are defined by having continuously available personnel, parenthetically neonatologists, neonatal nurses, respiratory therapists. You see that?
Yes.
You agree with that?
Well, it depends on, you know, parsing the words, what
Okay.
they mean by available and how, you know, they don't define that means you can't be across the street eating, you can't be at home, you can't be 10 minutes. You know, you're available.
Okay.
You're available for consultation by telephone. You have people in-house who can perform the duty. If that meets level 3 and the state certifies you as such, then you're a level 3.
Okay. You agree you can't intubate a baby over the telephone, true?
You shouldn't need to.
Yes, sir, but my question was a little different.
I can't intubate the baby over the telephone.
Right. Now, you believe that you could have a single physician be continuously available for level 3 NICU with no backup?
Objective form, ask and answer.
I believe you can do it. Do I believe that it's easy to do with no backup? No, I wouldn't want that job. But there are people who do it.
Yes, sir. And while people may do it, they also need to understand that at times, you know, if they don't have people with the requisite clinical experience demonstrated by large patient volume and increasing complexity of care, it may be in the patient's best interest to transfer that baby to a children's hospital. True.
Objective form.
If they don't have the personnel to take care of somebody, then they should transfer it.
All right. And in fact, that's here too. If you look on over on page 15, do you see where it says potential? Let's see. I'm having a hard time reading
Potential
upside down.
transfer
Yes,
to
sir.
higher level facilities.
Potential transfer to higher level facilities or children's hospitals like this one should be considered as clinically indicated. True?
As clinically indicated, yes.
Yes, sir. And if you've got a situation like this where you have a baby that can't be intubated and by the people in your unit, that baby needs to be transferred. True.
Objective form.
If you know that your people can't intubate the baby, but your reasonable expectation from their training is that they can intubate the baby.
All right. And you agree that a baby like Caden that's paralyzed, intubated on a ventilator that's doing the breathing for him and on an epidrip would be better off at a children's hospital than a 100-bed hospital that sees 1,000 patients a year than a 6-bed nursery that sees much fewer patients and doesn't have the same experience
Objective form.
and doesn't have a full-time.
No, I don't
neonatal.
agree with that.
You think it's the same?
I think that there are many logistic things that go into it that basically if you can provide the level of care that the child needs,
Yes, sir.
then the risk of transport does not outweigh the risk of staying in the hospital. Can a children's hospital do it a tiny little bit better because they can maybe draw less blood or they have more facilities and more people? Maybe, but that's got to outweigh the risk of transport. And if you are able to provide what this child needs, you shouldn't subject them to the risk of transport.
Okay. And NICUs get about, what, $4,000 a day for a baby?
Oh, I don't have any idea.
You don't know?
They don't pay me that.
Okay.
No.
And the transfer, it would, well,
I don't
Kate-
think they get, well, yeah, they may get that much nowadays.
Okay.
They didn't used to.
You don't
I don't
know.
know what they get
That's-
now.
now, Caden was ultimately transferred to Children's Healthcare of Atlanta, true?
Yes.
And there was no incident that you're aware of with that transfer,
No.
right? Okay.
No.
And of course, it would have been, if he were going to be transferred, it would have been better to have transferred him before the code than during the code, true?
Objective form.
Well, I would rather transfer him before or after the code than during the code.
All right.
Yes.
That was the question. Now, you read the testimony about the conversation between nurse practitioner Posley and Dr. Onasanya?
I read what they said in the deposition. I can't say I remember what
That's
that
all
was.
right. Well, as best as I can remember it, Nurse Posley called Dr. Onasanya. She told him what had happened. He asked her to repeat it, and he said he was on his way. Does that
Yes.
comport with your memory?
Yes.
And then he arrived, according to the record, about half an hour later. True.
According to that record, yes.
Now, and you read the respiratory therapist that tried to ventilate the baby. You read his deposition as well, Mr. Wright.
Lassingame and Wright, yes.
Mr.
I
Wright.
think. No, yes, I think I read Wright's deposition.
Mr. Wright, he was actually, well, first of
I
all,
was thinking might have been a nurse, but, yeah.
You were right.
What?
Okay, Wright is a nurse?
No.
No, Wright is, okay. I read Wright's deposition.
He's a respiratory
Yeah.
therapist, Anthony
I
Wright,
got
I
it,
believe is
yeah.
his name.
Okay.
And he was actually a part-time respiratory therapist, also a part-time real estate agent, had 2 active deals while he was caring for this baby. You were aware that he was a part-time respiratory
No.
therapist?
No.
Okay, but that doesn't change your view, right?
Well, not as long as he has people there who have more experience.
Okay.
Yeah.
Now,
Or he has the experience to intubate. I don't know him, and I'm not the one doing any kind of competencies for him or anything.
okay. According to the certified copy of the medical record and what you read, he was not able to successfully intubate the baby, true?
Correct.
Which led to the oxygen deprivation and ultimately the
Well, he was
brain
not
damage,
able, at least, whether he was able to intubate him or not, they were not able to ventilate him, and they removed the tube. Now, whether that tube was in the right place and they just didn't get chest rise or not, I don't know that.
And you don't
but,
have an opinion on that?
No.
And do you recall reading Ms. Posley's testimony regarding Nurse Scott's comment that the baby must have self-extubated himself?
Yes, they got no rise, and they said self-extubated, but I would say, I don't think that could also mean there was no chest rise and the tube was plugged, and that whatever it was, he wasn't ventilating, so they assumed he wasn't intubated, and they went to re-intubate him.
Have you ever had a 4.0 tube plug?
Oh, yeah.
Okay. Common?
Common enough that
Okay.
I've replaced quite a few of them.
Okay. If, assume this is another one of those hypothetical questions, I want you to assume for the moment that you can have irreversible brain damage and significant brain damage at 18 or 20 minutes. If that's the case, then if a physician is 30 minutes away, that's not going to do that baby much
good, right?
Objective form.
Well, I don't think the physician necessarily is going to do much good. I think he has a team in place that
Yes,
should
sir.
be able to handle all of that. So he's a ways away, and the further away he is, the less input he's going to get into the management.
Right.
But he can be, I mean, he's available by phone. If they need his intellectual input, they can get it. But as far as his hands-on skills, he's relying on the team he has in place.
Right. And the physician is ultimately responsible for the team he has in place to care for his patient, true?
Objective form.
There's some joint responsibility,
Yes, sir.
but ultimately the hospital is the one who's paying these people and responsible for that. He is, I mean, he has duties if he thinks they do not have the skills that they were hired to perform,
Yes, sir.
but I don't know that I am responsible for the actions of everyone who is hired by the hospital.
All right. It's a joint responsibility to do what you can do to ensure that your patient's properly cared for, true?
He leads the team.
Right. He leads it. So you agree it's a joint responsibility. He's as the team leader.
Objective form.
Again, these are hospital employees. As a physician, I'm saying I need a nurse practitioner, a competent nurse practitioner, a
Right.
competent respiratory therapist. And if I have those things and it turns out they've hired people that don't have the skills that they were supposed to hire, that's the hospital. That's not me. But if I have the people that I said I needed to have, a competent nurse practitioner and a competent respiratory therapist, then I had the team in place.
Gotcha.
And I'm not trying to shirk responsibility. I consider myself responsible for all of my patients, but
Right.
but I don't know how that fits. You guys know legally. I don't know about
Well,
that.
I'm not talking about legally. I'm here for your expert opinion about your role as a physician and looking after caring for your patient.
I
doing
lead the
what's in
team,
best
so if
interest
I
of-
don't think it's the best interest of the patient, I have a duty to say so.
Right, and you agree that as a physician, you have to do what's in the best interest of your patient, true?
Yes.
In order to assure the safety of your patient, true?
Yes.
That's of paramount importance to you.
Yes.
Now, you see about 500 patients a year here?
Here it's probably not that high anymore. I think we're down to about 400, might be even 380 or so this year.
Okay. Children's Healthcare of Atlanta, do you know Heidi Carpin? Dr.
No.
Carpin, Dr. Mohan? Ever
No.
worked with them?
No. I do know some doctors who are over there, but I don't know those.
Okay. Some of this, my outline, we've already covered some of that.
I hope so, because that's a thick book.
Well, we're going to go through. You agree that bronchospasm is extremely rare in a newborn, true?
True.
And that an infant that's a month old would have a much greater risk of a chronic lung disease than a baby that's 3 or 4 days old, true?
True.
You agree that the NRP does not recommend albuterol or Atrovent for bronchospasm, true?
No, I don't think it says anything about treating bronchospasm.
Right, and that's because you don't have it in a neonate.
You don't generally, you're not dealing with that problem, but
Right.
it doesn't say you shouldn't use it for that. You should use it for that,
But
only if you think they have bronchospasm.
yeah, the NRP doesn't cover bronchospasm because it doesn't.
It's just
Occur.
generally not an issue. But the NRP is what most people are trained in, even though they're taking care of older children, like here, and those children do get bronchospasm, but that's different than resuscitation. You can be coding and still have other medical problems that need attention,
Right.
such as bronchospasm. That may not be the reason for the code, but it may still be present and still need treatment in the midst of the code.
You said older children like here, you're not talking about Caden or suggesting he had bronchospasm, true?
I don't think he had
Gotcha,
bronchospasm.
that's good. I mean, that's
Yeah.
fine. Do you agree that pulmonary vasculature can be sensitive to various stimuli and constrict the smooth muscle arterioles in a newborn, which can cause a shock but not a bronchospasm? True?
True.
Do you recommend bronchodilators for an infant that has transient pulmonary hypertension?
I don't generally use them for that, no.
Okay. Can you think of any text, treatise, peer-reviewed article,
Well,
non-peer-reviewed article?
pulmonary
that's-
hypertension
I agree
is,
with you.
well, but pulmonary hypertension comes in a lot of flavors and from a lot of different reasons.
Right.
And there are kids, and this is generally the older kids again, who have bronchospastic
Caden.
things, older than Caden, a month old,
Right.
have bronchospastic things and chronic lung disease and do respond to albuterol. But in his case, pulmonary hypertension or not, I would not think he had bronchospasm or would benefit from the albuterol.
Have you ever seen a newborn baby in the first few days of life develop asthma?
That's another of those things you can't diagnose at that age, even if you thought they were developing it, so no.
Caden did not have a bronchospasm, true?
Objective form asked and answered.
I don't believe he had a bronchospasm.
Or
I'm
pneumothorax?
not saying he couldn't have had one.
Okay.
And he did not have a pneumothorax from any x-ray I looked at.
Gotcha. And he did not have bronchopulmonary dysplasia, true?
True.
Okay. Dr. Coghill, you agree a level 3 NICU can be staffed by a single neonatologist, true?
True.
And that single neonatologist can provide the continuously available personnel such that he's supplying continuous care, true?
Yes.
Do you think if he had, for instance, a family emergency or a flat tire, an issue like that, and there was no backup, that could create an issue?
Objective form.
Well, so could a snowstorm or an earthquake. I mean, yes.
Okay.
I mean, some hospitals won't allow that.
Won't allow what?
Won't allow a single physician without a backup physician.
Okay. Well, but as a doctor, you have to do what's in the best interest of your patient, true?
True.
So if a hospital just because a hospital allows it doesn't mean you ought to do it. If it's going to
No, I
endanger your
mean,
patient.
I
true?
would-
Hold on just a second. Objective form is very broad and objection stands. You can answer that.
I think your backup could be simply that they're going to transfer all the patients out of the hospital if you're not available. You know, as I said, I wouldn't want the job, but whether you're competent, whether it had any basis on the care of this patient would be, you know, if you tell me that his 24/7 means he's awake 24/7 all year long, then I would say no, he can't do that. But if he's sleeping most nights and there's not much happening, you know, I cover hospitals for a weekend. I don't have backup on the weekend. I mean, we would call the person here at UAB and get them out and come help us if we had to, but you're really floating without backup in those hospitals
Right, on a weekend.
on weekends.
Now, residents, they can only work 8 hours a day, true?
I think first year is 16, and then they can work longer hours their second and third years, and that's about to change again in all likelihood.
Okay. So, but, I mean, can they work 24 hours a day?
The upper levels, yes.
Okay.
Yeah. I think they might have some 15-minute nap requirement. I don't know.
So your testimony is that in this case, whether Dr. Onasanya stayed with the baby or left the baby without a doctor or transferred the baby, you would have been indifferent to any of those choices, true?
I think you were at risk for the exact same outcomes regardless of those three choices.
Same risk.
The same risk.
Okay.
I mean, this dude could have come out when you put that baby in the ambulance to transport him. It could have been the same self-extubated crash. Somebody was going to have to put the tube in. It wasn't Dr. Onasanya who put it in. Somebody's going to have to manage him. The management wasn't much different than he did once he's arrived. So I think the care would have been the same either way.
And if you look at your disclosure, I think it was Exhibit 2. Yeah. That's all right. Where it's never right to needlessly endanger your patient. True?
Asked and answered twice, I
Yeah.
believe.
That's true.
We agree that Caden did not have intrapartum asphyxia at birth. True?
I don't believe he did, no.
And he was non-encephalopathic at birth, normal Apgars, right? All indicative of no intrapartum asphyxia, true?
True. Now, he had RDS at term, which there was some early bleeding, early trimester bleeding. Mom got some betamethasone at like 24 and 5. He came in for some stress testing or biophysical profiles twice before delivery. So this wasn't just normal. There's no chance that there wasn't something prenatally going on. But I don't believe that that was a significant contributor to his illness.
Okay. You agree that a tension pneumothorax did not cause Caden's acute event, true?
I agree.
Wouldn't it be in the best interest of a newborn like Caden who requires skeletal muscle paralysis for significant respiratory distress syndrome and has evidence of pulmonary hypertension to have a physician in the house?
No.
This one.
Okay. You agree the most common cause of neonatal compromise is an inadequate airway?
Yes.
You agree that this 53-minute code was directly related to the inability to provide an adequate airway?
I don't know that they didn't have an airway. They couldn't ventilate him.
Okay. Which could be attributable to not having an adequate
Well,
airway.
it could be the it could be the airway, or it could be the lung.
Well, at the conclusion of the code, the lungs everything's working but the brain, right?
Well, the heart's not working perfectly, but the lungs are not working. I mean, the right lung is completely opacified, and so there's something going on in the lungs. It's not normal. The autopsy shows a lot of neutrophils there. It's not normal.
Right.
I would say, and the lungs are not normal. I mean, it's maybe a trivial event, but he has isomerism with both sides having 3 lobes, which is not normal.
Right.
But that right lung is especially not normal.
Right. And you looked at, I mean, that happened over the course of 3 or 4 days, right?
Well, he had some wandering atelectasis, but the whole right side is either during the cause of the code or during the code, but I mean, they are temporally tied together. Whether
Right.
what's causative is what's the chicken and the egg, I don't know.
All right. What happened on the 12th or 13th then? On the 12th?
Yes.
Okay. You would agree that if you had a paralyzed newborn that was critically ill, as this baby Caden was, the best place to care for him would be a level 3 tertiary center with in-house fellows or attendings like Children's Healthcare of Atlanta. True?
Check the form.
No, I don't think that's true.
Okay. You could, I believe I read you coordinate the call schedule for Grandview, Princeton, Shelby Street, Vincent East, and Medical West. Is that right?
Yes.
And how many NICU beds do each of those have?
Medical West is just a stabilize and get out of there unit. Princeton, since in Alabama you don't license beds if
Okay.
you're a delivery unit. So Children's has licensed beds because we don't deliver.
Okay.
But if you deliver, you don't have licensed beds. You can have however many you need to have, however many you can staff.
Okay.
So Princeton has had as many as 10. Their average is maybe 6.
Okay.
Grandview has had as many as 20, 23. Their average, though, is only about 10.
Okay.
And Medical Center East has had as many as 10 or 11. Their average is probably 5, 6.
All right. And Shelby Street, is that?
Shelby is, wait a minute. I did Princeton, I did East, I did Grandview. Shelby is virtually the same, 10 and 6. I think 10 beds, as many as 10 have been there, and they have
Okay.
about 6 on average.
And these are, which ones of these are level 3?
They're all level 3
All level 3.
now. And there are 2 larger level 3 nurseries in town, but we don't cover them.
Okay. And what's the name of your group?
UAB.
Okay. Do you remember what time Dr. Onasanya left on the 12th?
No, I don't remember.
You agree that when he left, this baby was very sick, true?
Check the form.
The baby was critically ill. Yes.
Critically ill. And you don't have an issue with taking 30 minutes to get there once he got the call, true?
No, I don't have a problem with that.
Or knowing if it's going to take him 30 minutes, not getting a colleague that can get there quicker, true?
True.
You were party to the lawsuit, not a party to the lawsuit.
I was named in a lawsuit, but I had only done the discharge summary and wasn't the one who took care of the patient, so they dropped me prior to trial.
Was that here in Birmingham?
Yes.
You remember the plaintiff's name?
No,
Okay.
no. It was probably about 1995 or so.
Do you have, what's your opinion about why the nurse practitioner Posley did not attempt to intubate the baby in this case?
Check the form. Cause for speculation.
Yeah, I don't know. I assume that, you know, if I'm there and the respiratory therapist is competent to intubate and they've intubated for me or in front of me before and they pick up the laryngoscope, I'm perfectly happy running the code. It's easier to run the code if I'm not doing procedures. So I'd rather step back and have others do the procedure if they're able.
Okay. You agree that Caden's injury was acute and profound, true?
True.
In your article you published in Respiratory Care, June 1991, page 596, you stated that assisted ventilation, quote, has been complicated by high morbidity. Can you tell me what you meant by that? You want the article?
There are lots of deaths with ventilation.
As a result of?
Well, as a result of the use of too much pressure, inappropriate use of the ventilator, tracheal injuries from poor humidification. I mean, it's just not you don't want to get ventilated if you don't have to.
Do you agree that in this case there was appropriate use of the ventilator between the 8th and the time of the code?
Yes.
Okay. You don't have any issues with anyone's care from the time of birth on the 8th until the code, true?
True.
Well, you don't have any issues even over the course of the code either, true?
I don't have any issues. I think it was done. Is it how I would have done it necessarily? No, probably not. But then if you're not sitting there doing it, it's hard to say because so much of what I'm going to do is dependent on what I have people telling me and what I see at the time of the code. I'm not looking at a monitor, I'm looking at a piece of paper here. So it's a little bit different if I'm listening to that baby and I think I hear some squeaking, then I may go with albuterol. But if I don't, I may say, no, I don't want that.
Well, based on what you do know, what would you have done differently?
I wouldn't have given as much calcium and I wouldn't have fooled with the albuterol.
Okay, what else?
I don't think there's really anything else I would have done. You're doing the chest compressions, trying to make sure that they're adequate and
Okay.
that you're getting a response, but he's slow to respond.
Now, you read Nurse Scott's deposition, true?
I don't think I read her deposition.
Do you agree that if you had a nurse caring for a patient and you were using surfactant therapy, that you would want that nurse to know what surfactant was and how it works and whether you can tell whether there's an improvement in the patient?
Objective only.
I would love for my nurses to know all of those things, but they don't know that about a lot of medicines they give.
Okay, including surfactant.
If you went out there and questioned every nurse I've got, you'd find some that don't understand surfactant.
Okay, and that's okay.
I don't know that I think it's okay. I mean, I teach them all the time. That's what I do on rounds, is try to help make sure they understand what it's for and why it's there. And I think the more educated everybody is, the better. Mm-hmm. But what I care about is that they can deliver it. And if they can deliver it and don't understand what it really is, that's not ideal, but it gets the job done.
What you care about is your patient, true?
I care that the patient gets it.
Right. And if you found a nurse that really, as you suggested, a not ideal situation, she really wasn't as versed as you would like, and surfactant, would you try to get a different nurse, or?
Well, I would, first you have to figure out that she doesn't know, but I mean, as you're sitting on rounds and you talk about it, if they don't seem to know or understand, then it's a teaching moment. It's a time to help them through what it's for and why we're doing that, and part of that just trying to encourage them to ask questions. But you know, surfactant, no surfactant, whatever, yeah, I want them to be able to give it. I'd love them to know everything about it. I'd love them to know as much as I know about it, but they're not going to know that much.
Well, but whether they know as much as you know about it, you'd like for them to know, you know, whether it's working or not. So, because when you're not there, that nurse is your eyes and ears. So
Now,
she's
the nurse
the one to alert.
practitioner should know. I don't know the nurse should know. I mean, the nurse has to know how to deliver the medicine. She does not have to know how every medicine works. They don't know how most of the antibiotics work. They don't know how most of the chemotherapy agents work. And I don't know whether it would be a terrible benefit for them to know those things.
Well,
so surfactant is fairly simple and common. I'd like them to know, but antibiotics are very common. And they know which antibiotics we use, but they don't know how they work on cell walls or whatever. They don't need to know that.
right. Well, surfactant, I wouldn't, talking about, you know, how it works on the tissue in the lungs, but
Yeah.
knowing, you expect a nurse to tell you what's going on when you're not there, true?
I do, but that's really the nurse practitioner is my eyes and ears. And I have nurses who are excellent and who I believe could do the job of a doctor, and I have nurses who I think I need to watch everything they do. I need to pay attention, and that's just knowing your staff and who's strong and who's weak and where they go. I'd love them to know. But I don't want to get too into surfactant because I don't think it played a part in this, but go ahead.
Surfactant didn't play a role in the baby's brain injury, true?
True.
It was the inability to, it was the.
The
what you
RDS
told
was
me
over.
before go ahead.
The RDS was over. Whether you gave surfactant or not, the child was getting better at this standpoint.
On the 12th.
Surfactant might have made them not get as sick as if you don't give surfactant, but surfactant itself, after 3.5 days, you're getting better. I don't care whether they gave you surfactant or they didn't.
Okay. What opinions do you have regarding this case that you haven't shared with me?
Well, I shared to some degree that I think that this child had some lung disease going on. The fact that the sibling was febrile and that this child, I believe, actually ran some fever at Children's of Atlanta.
Sibling was febrile. What sibling?
The sibling, this child's sibling, a brother or sister. The records at Atlanta say the child's sibling had fever, which would suggest that the sibling had a viral illness, and whether that had been transmitted to this child and this pneumonia, viral pneumonia, was what made this child get worse on the day that he coded, I think is a real possibility. And viral pneumonias can cause wheezing, could cause bronchospasm. It still wouldn't have been high on my list, but I don't know about this fever at the time, but I know about it from reading the records, and I know that there were white cells in that lung, and I know that a viral pneumonia could cause you to be getting better from your RDS and then turn around and start getting worse from some other cause, that it could cause mucus plugging, and that may have been what caused the code to occur and not some dislodged tube or other problem.
Okay, so your view is that a viral pneumonia rather than a dislodged tube.
Oh no,
let me.
okay.
I'll let you.
Okay.
Okay. You mind reading back what I?
So your view is a viral pneumonia rather than a dislodged tube.
Gotcha. So your view is a viral pneumonia rather than a dislodged tube is what caused the code in the first place.
Objective form is characterized as
I'm
testimony.
not going to necessarily say one was more likely than the other. I'm saying they're both pretty much in my differential.
Okay. What else is in your differential?
The mucus plug, which could be from viral pneumonia or could just be from the fact that you're ventilating the child. Even though I would put it very, very low, a severe bronchospastic event, but
Okay.
I'm telling you that would be, I mean, it's there, but it's very low.
Okay.
And those are pretty much
That's it.
things. I mean, you could have pulmonary hemorrhage, but there was no evidence of that. I mean, there are a lot of other things that I know from autopsy and other things didn't happen.
Okay. Do you feel like the autopsy was doctored as Dr. Onasanya testified?
Autopsies are done with some limited clinical information, a little bit of best guess speculation. I don't know that it's doctored. I just don't know that the doctors doing the autopsy don't have clinical experience in many cases, and I don't always agree with the findings of our pathologists on autopsy. But I don't know that I would call them doctored. It's just different opinions.
Right. And that's my question, and you answered that question, and thank you. My question was whether you agree with Dr. Onasanya that the pathologist at Children's Healthcare of Atlanta doctored his report.
Objective form.
Well, I don't think, I didn't see that allegation or didn't catch it in that verbiage, but if that's what he said, I would say, no, I don't believe any reports were doctored.
All right. Anything you feel like Dr. Onasanya could have done differently here?
No.
And what is your opinion regarding Dr. Onasanya's care?
I don't see any problem with it. I think it's routine.
No problem, routine.
Routine.
And you don't have any criticisms of the nurse practitioners, PAs, RTs, or RNs, true?
True, but I did not review this as a nurse expert. So
Right,
I
and
didn't see anything in what I saw recorded or their responses that made me concerned.
Okay. Would you, and you'd paralyze a baby and leave it with critically ill with a nurse with limited experience, right?
Objective form.
We leave it with a competent team. I don't
Competent.
leave it with if limited experience means they're not competent. I mean, I have great practitioners almost straight out of school, and I have some that require retraining.
You have any criticisms regarding the placement of the ET tubes?
Well, I don't know that the first attempt in the code, I don't know that that tube was in or was not in, but they weren't able to intubate the child and get ventilation, but I don't have any criticism of it.
Okay. You agree that infiltrates associated with RDS in neonates are usually caused by either pneumonia or mucus plugging, true?
No, I wouldn't say that's true. I would say those are possibilities, but I wouldn't say that I couldn't use that that's how they're, that that's the cause, because the wandering atelectasis may just very well be that the surfactant you gave only gets in pieces of the lung, and those pieces are more healthy than the pieces it didn't get in.
Okay. Others?
Ventilation is not equal throughout the lung, so depending on the position of the child, I mean, you turn them, as often when you get atelectasis, you turn the side that's down on up, so that you use gravity and
Right.
you use the difference in pressure to help open up what was collapsed. But that's not necessarily a mucus plug, though a mucus plug could have led to it. But it's just the fact that when you blow into the lungs, every lobe of the lung doesn't get exactly the same pressure, and they don't behave exactly the same way.
Any
and
issue-
the sicker they are, the less they behave equally.
Any issues with turning the baby in this case?
No.
You agree that the proper place for UVC is not the liver, true?
True.
You didn't do any research, right?
No.
Did you speak with anyone else about this case?
No.
Show you what is what mark
Right next to you, to the right, underneath that paper.
oh, thank you. Show you what's been previously marked as Exhibit 8. These are some Georgia regulations. You've not seen those before today, right?
No.
Have you turn on over to page 9?
James, what regulations are you referring to?
This is 11-8-40.34 maternal and newborn services. If you look at page 8 to begin with, at the bottom, reads here, 5, the hospital, let me show you, right in here.
Okay.
The hospital providing the intensive level of services shall meet all requirements for basic and intermediate maternal and newborn services with the following additions and/or exceptions. You've not seen that before today.
No.
Under B, the director of intensive newborn services shall be a member of the medical staff who is a board-certified pediatrician or board-certified neonatologist. You see that?
I see that.
And it's your understanding Dr. Onasanya was a board-certified neonatologist, true?
I don't know. Don't know
Okay.
that.
And it doesn't make any difference to you?
His care was performed well. Whether he was board certified or not board certified, I don't know.
Okay. And C, the hospital shall have on-call a 24-hour basis a board-certified obstetrician or maternal fetal medicine specialist to provide on-site supervision and management of maternal patients. You've not seen that before today, true?
True.
E, the hospital shall have on-call on a 24-hour basis a board-certified neonatologist to provide on-site supervision and management of neonates. Not seen that before today, true?
True.
Doesn't change any of your views, right?
Correct.
You think one man can do that, right?
Is that the form, ask and answer?
It depends on the patient load and how much sleep you can get. I don't know it's only a 6-bed unit, and I don't know, I don't know. I wouldn't want the job, but
Right.
I think you could do it
And you wouldn't want the job because,
because they would call me too much.
okay. I'll show you what's been marked as exhibit number 9. This is American Academy of Pediatrics article. You're a member of that group, right?
Yes.
And if you look at page 593, talking about level 3 NICUs,
Okay.
at the bottom of the first column, at last sentence, designation of level 3 care should be based on clinical experience as demonstrated by large patient volume, increasing complexity of care, and availability of pediatric medical subspecialties. Do you see that?
Yes.
And it goes on to read, subspecialty care services should include expertise in neonatology. True?
True.
It goes on to read, continuously available personnel, including neonatologists, right?
Correct.
Then if you look down at the, and you agree that they need to be readily accessible, right?
Well, again, they don't define what readily accessible means. That's open to a lot of interpretation.
30 minutes away is okay, in your view.
Yes.
Okay. All right, any other opinions you haven't shared with me? That's all I have.
Oh,
No questions?
Nice to meet you.
nice to meet you. Thanks.
This marks the end of this 2. We are off the record at 8:04.